Okay.
Yep. Thank you. Yeah, therefore I will move on to introduce the next speaker, Professor Olivier Glehen. I think I don't have to introduce him. Professor Glehen is the pioneer, one of the pioneer for the HIPEC and also peritoneal carcinomatosis, has published extensively in the field. So without further ado, Professor Glehen, please.
Thank you, Jimmy, for the organization, for your invitation. It's always an honor for me to be part of this discussion. I would prefer to see you in live, but we have to adapt. And it's a good thing to be able to exchange about this very important topic. Everybody is seeing my screen,
yes.
yeah?
Yes.
Yeah. So we will speak now about specifically about the HIPEC. We thought that we need a systemic chemotherapy, that we have some hope from immunotherapy, that intraperitoneal chemotherapy without it is giving, I found, very impressive results. Congratulations to Dr. Ishigami. So this is my disclosure. So how can we use HIPEC? I think that the most commonly used is in combination with cytoreductive surgery to apply a curative treatment. But, and you know that we evaluated with this, it can be used also as prophylactic treatment in combination to a curative gastrectomy when you have no peritoneal disease. And more, we can use also as a palliative or neoadjuvant treatment, especially with a laparoscopic approach. I will speak about this at the end of my talk. So in the curative approach, when you look at the results of all the peritoneal metastases from digestive cancer that were treated in France with the combination of cytoreductive surgery and HIPEC, you all know that, of course, peritoneal metastases from gastric cancer are given the lower results with poor survival, but with some long-term survival. We have one randomized trials that were conducted by Yan Li, that was published some years ago, and that compared for gastric carcinomatosis, cytoreductive surgery alone, and cytoreductive surgery and HIPEC that combine cisplatinum and mitomycin. And when you look at the results, HIPEC significantly improves survival, especially on patients with synchronous peritoneal metastasis, and did better for this condition than for metachronous peritoneal metastasis. We tried in Europe to conduct, especially in Germany, the same trial incorporating the standard of care in Europe, that is the perioperative systemic chemotherapy using an oxaliplatin regimen. Unfortunately, despite the effort of Beate Rao, that was the that had the leadership of this trial was unfortunately closed because of insufficient recruitment, as peritoneal, as gastric cancer has a lower incidence than in Asiatic countries. And you can see that in this study, HIPEC used were combined cisplatinum and mitomycin. I hope that Beate will be able to give us, not of course all the results, but the preliminary results to have an idea of the effect of HIPEC in this situation. We have, of course, meta-analysis that demonstrated that intraperitoneal chemotherapy is working in case of the treatment of peritoneal metastasis, but as you can see, there is not a lot of studies, and most of the studies were Asiatic. So when you think about the potential benefit of HIPEC, especially when you combine gastrectomy that has a major impact on the quality of life of your patients, you have to know if it's possible to cure them. And it is a question that we asked into our database in France. And we defined a patient as cured when the patient had no event, no recurrence, no treatment during 5 years. That is, for me, acceptable. So all patients that had a complete cytoreductive surgery in France that was combined with HIPEC were reviewed to establish the rate of patients that could be considered as cured. And as you can see, 10% of these patients could be considered as cured. All had synchronous peritoneal metastasis. All had a very low PCI, as you see, because no patients had PCI more than 6. All were, of course, treated by a complete cytoreductive surgery, but some of them had some poor prognostic factor, like pathology incorporating signating cells. All patients were treated with HIPEC that were performed for 90 minutes with mitomycin or cisplatin. But we wanted to go in another way to demonstrate the benefit of HIPEC. And I had the privilege to conduct this study with Christophe Mariette, who was an excellent surgeon in the field of esophageal surgery, and who unfortunately left us too early. He was at the head of the FREGAT database that included all esophageal cancer treated in France, and I was at the head of Big RENAP that included all patients with peritoneal metastasis from digestive cancer. And we decided to compare cytoreductive surgery alone versus cytoreductive surgery plus hyperthermic intraperitoneal chemotherapy. And we were able to compare 180 patients treated with CRS and HIPEC to 97 patients treated by cytoreductive surgery alone. To make the comparison as good as possible, we used a propensity analysis, and we were able to obtain 2 groups of patients despite the retrospective design that were comparable. They all had, as you can see, very poor prognostic factor with a high proportion of patients with lymph node involvement and with signature cell pathology. But we did not succeed to make them really comparable with the principal prognostic factor, which was the PCI. And when you look the median PCI in the HIPEC group, it was 6, and only 2 in the group treated by cytoreductive surgery alone. And despite the fact that the patients had worse prognosis because of this high PCI in the HIPEC group, HIPEC did significantly better in terms of overall survival, but also in terms of disease-free survival. And this difference was significant in all models that we did. When you look now at the subgroups that were analyzed, you can see that HIPEC had its significant improvement in all subgroups that we analyzed. In patients treated by CC1, in patients with poor pathology, in patients with lymph node involvement, and irrespective of the use of adjuvant therapy. And when you look at the postoperative complications, HIPEC did not significantly increase the rate of mortality and morbidity following the procedure. So when you look now at the HIPEC that were majority performed in this study, all were performed with the use of cisplatin alone, mitomycin alone, or cisplatin and mitomycin combined, and for 90 minutes. The conclusion of our study was that in selected patients with localized and limited peritoneal metastasis, HIPEC combined with complete cytoreductive surgery should be used to increase overall survival and disease-free survival. But how to select these patients? Because this treatment was delivered to patients that were strictly selected into expert centers. The first thing is that we have a great heterogeneity in terms of survival results regarding the institutions where the treatment was delivered. And I think that we need, for good results, institution experts in esophageal surgery, but also in the management of peritoneal surface malignancy. Of course, we should propose this treatment only in patients for which a complete cytoreductive surgery can be achieved, because in patients treated by CC1 or CC2 resection, we had a very low median survival. But now, what about two very important prognostic factors, that was the pathology and the presence of signature cells, adenocarcinoma, lanitis, and about the PCI. As you know, of course, the presence of signature cells cancer led to a lower prognosis, and it was confirmed in our cohort. Now, when you look at the impact on HIPEC, combined or not, on with cytoreductive surgery in the particular group of patients with signature cell cancer, you can see that HIPEC also significantly improve the survival. And you can see that this difference was higher in the group of patients without this poor prognosis pathology. When you look now on the type of recurrence in patients treated or not with HIPEC, you can see that HIPEC significantly decrease the rate of peritoneal recurrence. So by adding a treatment into the peritoneum in a patient with a peritoneal metastasis with HIPEC, you will increase the overall survival by decreasing the rate of peritoneal recurrence. And now another thing that is for me very interesting, to select the appropriate patients. As you know, we are using some cutoff of PCI in many peritoneal surface malignancy, and I think that we probably should use some PCI cutoff to appropriately select our patients. So when you see patients with poor signature cell cancer, you can see that when the PCI is higher than 7, the prognostic dramatically decrease. But in patients who had not this poor prognosis pathology, even when PCI is between 7 and 12, you obtain exactly the same results that with PCI that are lower. So it's not a definitive conclusion, but I think that regarding these results, we should define a PCI cutoff that is approximately 7 when you have this poor prognosis pathology, but you can increase at 12 when the patients had no non-signatory cells pathology. So how to select these patients with a very low PCI? You have to perform as soon as possible a laparoscopy to detect these small peritoneal metastases that are not visible on the morphologic exam. And you may have sometimes this diffuse involvement without any sign on the CT scan or on the PET CT scan. And the particularity of the laparoscopy that we should do is probably to combine this laparoscopy with a palpation of the small bowel, and you will avoid, especially in patients with signature cell cancer, the open and close procedures for patients that are not amenable to a complete cytoreductive surgery. And this involvement is sometimes not visible on a regular laparoscopy. So now one word about the influence of lymph node, even if this prognostic factor will be obtained after the procedure and not before the procedure. We also find an interesting finding, which was that in case of peritoneal metastasis, you have no impact of N1 and N2 status. The patients with peritoneal metastasis that were treated with a curative intent, even if they are N1 or N2, they will have the same prognosis that the patients without lymph node metastasis. But in case of N3 status, you will decrease the overall survival. So now one word about the place of HIPEC in prophylactic setting. This is probably one of its best place, as you know, because we all know that patients with advanced gastric cancer have a high risk of peritoneal recurrence. And if you can prevent this recurrence, you will for sure increase the prognosis. We all know that the patients that are at risk of peritoneal recurrence, the patients with linitis, the patient with lymph node involvement, serosal involvement, and of course, the patients with positive cytology, even if these patients could be considered already as a peritoneal metastasis. We know also in this meta-analysis that intraperitoneal chemotherapy may improve the prognosis by preventing this recurrence. You have several Asiatic studies that already demonstrated this. And not only by decreasing the recurrence into the peritoneum, but also, surprisingly, by reducing hematogenous recurrences. But we all know that the gastric cancer in Asiatic countries are really different than patients that the gastric cancer in Western countries. And it's less complicated to operate this kind of patients than this kind of patients. So all what was demonstrated in Asiatic countries should be demonstrated in our Western countries. This is the reason why we decided to conduct and to begin a lot of years ago now, this GastroShip trial with the help of Alfredo Garofalo. All patients had advanced gastric cancer, but with no peritoneal disease. They all were treated with perioperative systemic chemotherapy and a curative gastrectomy. And intraoperatively, we randomized the use of HIPEC with an oxaliplatin regimen. We decided to improve the 5-year survival from 30% to 45%. And for this, we needed to include 321 patients in order to include and to randomize, approximately more than 300 patients. And we decided to stratify on signature cells and on centers that are important prognostic factor. When you look at the safety evaluation that we did at the beginning of the study, we had no increased mortality and morbidity in the HIPEC group. And unfortunately, because of the discovery of a lot of unknown peritoneal disease, which are an exclusion criteria, we had to increase our number of inclusion to be able to randomize the appropriate number of patients. I think that this is a very important information because all the patients to be included should have a laparoscopic evaluation. And despite this, during the curative procedures, we had this very high rate of 60% of patients, 12% of patients that had peritoneal metastasis. One word to finish about the use of HIPEC as neoadjuvant setting. We saw that we can use intraperitoneal chemotherapy, we can use HIPEC, but you can use also HIPEC in a laparoscopic way to try to control the peritoneal disease. The surgeon that probably had the most important experience in this situation is Yukata Yonamura, that began with the use of NIPS alone and that combine now NIPS and laparoscopic HIPEC. As you can see, he reported a very high response rate of approximately 60% of patients when patients were treated with HIPEC by laparoscopy. But when you compare its results with laparoscopic HIPEC and NIPS, HIPEC did not seem to really increase the response rate. Another guy decided, and it was my moderator, to evaluate this laparoscopic HIPEC in this setting using mitomycin and cisplatinum that may be repeated and that may follow the response of the peritoneal disease during the treatment that is combined with systemic chemotherapy. He validated this way of treatment into a phase 2 trials, and now he incorporated the use of this laparoscopic HIPEC in the process of the selection, because the selection of the right patients for a curative or palliative procedures is, for me, fundamental. And he's using HIPEC a little like we are using in France HIPEC to select this kind of patients. So in my conclusion would be that cytoreductive surgery and HIPEC should probably be considered for some gastric peritoneal metastasis from gastric cancer as a curative approach, as there is a potential of cure and that you may really improve the overall survival. You should take into consideration some very important prognostic factor, the possibility of complete cytoreductive surgery and the PCI. And the cutoff of this PCI should be, for me, different regarding the pathology. Probably less than 7 in case of sphenoid cell cancer, and probably less than 12 only when you have not this poor prognosis pathology. The laparoscopy in the management of these patients are fundamental and will detect the right patients as soon as possible. The use of a prophylactic HIPEC should still demonstrate its benefit, and I hope that I will be able to show you the results of GASTRI-SHIP as soon as possible. I think that the place of neoadjuvant HIPEC should be evaluated more. Thank you very much for your attention.
Thank you, thank you, Professor Glehen, for the wonderful and comprehensive lectures and give us so much data on the HIPEC for gastric cancers. I certainly agree with you. Laparoscopy is essential, especially we are dealing with locally advanced gastric cancer. Thank you so much. And I think just now the webinar was quite well received. We have over 200, and now we have over 220 participants.